This is a review of the NIRS Regional Oximetry Monitoring System that we use here at Boys Town. We use the Covidian brand that connects right to our Mindray monitors. So this regional oximetry monitoring can be used on cerebral monitoring as well as somatic and renal monitoring. The types of patients that we'll see this used on primarily would be a septic patient, shock patients, and some respiratory patients prior to and after extubation. So we carry both the pediatric neonatal size sensor as well as the adult sensor. The manufacturer uses 40 kilos as the cutoff of deciding which sensor to use, but really it's going to be based off the size of the patient, both in deciding which sensor to use as well as whether you're going to do unilateral or bilateral monitoring. The NIRS cords, sensors, and preamplifiers are all located in the storage closet between 201 and 202. When you're setting up a patient on the NIRS monitor, there's a cheat sheet Mindray setup located in the ACU nurse binder. This is going to have information on changing your load limits, your baselines, your labels, as well as your alarm settings. So for this patient, if we were applying the adult sensor probe, we would first prep the site. You're going to use an alcohol wipe and clean the area. Allow it to dry completely. You're going to need your adult sensor probe as well as your reusable cable connector. I already have my preamplifier plugged into the Mindray here. So once the site is completely dry, remove the backing, place it on the right or the left side of the forehead, and then you're just going to smooth out the edges to get a good seal around that sensor. You just don't want any light to be able to enter and interrupt that reading. Once that's connected, we'll connect the sensor to the cable. And then this reusable cable will connect right into the preamplifier. So if you were doing bilateral readings, you would do the same on the other side, grab another cable, and that would connect here. So you can do 2 adult sensor cables or 2 pediatric, but you can't intermix the 2. So if we're using that infant neonatal size, the difference is you won't need that connector cable because the sensor comes with a disposable cable already built in. So again, we're going to have our preamplifier already plugged into the Mindray. We're going to use an alcohol wipe to prep the site and allow it to completely dry. Remove the paper backing on the sensor, and then apply it to either the right or the left side of the forehead, avoiding the hair. And again, smoothing out all the sides to keep the light from entering and affecting the sensor reading. So this disposable cord directly connects into the preamplifier. And again, you can use 2 of these sensors if you were doing a cerebral monitoring and then also a renal. You just, again, can't mix and match the adult and PD sizes. Daily, we're going to remove the sensor to check the skin integrity underneath the sensor. You can use the same sensor for up to 48 hours, and then if you're going to continue monitoring, you need to remove the sensor, give the skin about an hour, and then check the skin integrity. If it looks good, we're going to clean the site and place a new sensor. Ideally, we want to keep the sensor in the same location for continuity of monitoring. However, if the skin looks like there's some breakdown happening, we'll go ahead and move that monitor site. So your typical cerebral saturation numbers are going to be 60 to 80. You'll get your baseline for your patient when you first set them up. If you do notice a drop in that reading, you want to ensure that your sensor is correctly placed and adhering well, and then also make sure that their head is midline to rule out mechanical causes of the drop. If neither of those are the issue and you do have a 20% change from that baseline reading, you're going to want to notify the provider. And then just a brief review of what needs to be documented. Your regional saturation is going to be documented with your vital signs. Anytime you have to notify a provider about that 20% change in baseline and any follow-up orders that they give you, your daily skin site assessment, and then any clinical interventions that would be expected to change that oximetry reading, such as a fluid bolus, initiating or weaning vasoactive drugs, or any kind of vent changes, those should be documented with the actual time so that we can correlate those changes in oximetry to those clinical interventions.